this second event in our new Big Questions series at the Center for Ideas in Society. And today we're asking the, I think, indeed big question, what happens when we nearly die, when we die? We're joined by three leading experts who will share with us their expertise in a unsettling but also quite fascinating medical and ethical and legal field. And two of them are critical care physicians who both are also trained and interested in the complex issues of bioethics, William Stigall and Brigham Willis. Our third guest is a well-known philosopher who has published extensively on death and near-death experiences, John Fisher. So a very exciting mix of speakers. My name is Jeanette Kohl. I'm co-director of UCR's Center for Ideas in Society. And when I'm wearing my other hat, I'm an art historian with an interest in the growing field of medical and health humanities. So that's one of the reasons why I'm particularly excited about today's event, as I'm sure you are. An event that is part of a new initiative at the center that brings the humanities in dialogue with the medical field. And there are more events to come. We also already had one with David Lowe on the COVID-19 pandemic in January. So how's this going to work today? Just a couple of quick housekeeping items after my short introduction and the introduction of the panelists. They will engage in a conversation that will be moderated by John Fisher. At around 2:50, 2:55, probably, I will open the discussion to your questions so that we have a little over a half hour for Q&A. So please feed your questions into the Q&A of this webinar as they occur to you. You can also vote questions up. This meeting will be recorded and closed captioning is available through your Zoom menu. Before I introduce the panelists and say a couple of words about today's topic, I would like to acknowledge that what we are doing today takes place on the traditional homelands of the Cahuilla, Tongva, Luiseño, and Serrano peoples, and express our gratitude for the opportunity of living and working on their lands. I also would like to intend a warm thank you to our panelists for making time in their very busy schedules. And I wanted to thank the rather large group of attendees today. The center is happy and delighted to see that this topic is of interest for so many of you inside and outside of UCR. So welcome all. Let me introduce our three panelists. John Martin Fisher received his BA in philosophy from Stanford and his PhD from Cornell. He has published widely on big questions such as free will, moral responsibility, and the ethical and metaphysical issues surrounding death. From 2012 to 15, he was the director of a large multi-million-dollar project, the so-called Immortality Project, funded by the John Templeton Foundation. He's currently distinguished professor of philosophy at UCR and the first and only philosopher ever to be a university professor in the University of California. William Stigall, MD, MA, graduated with a BBA in business honors from UT Austin and an MD from UT Southwestern in Dallas. He's a practicing pediatric intensivist at Cook Children's Medical Center in Fort Worth, where he's also the medical director of the Human Research Protection Program and chair of the IRB. He's a practicing and teaching bioethicist who holds a master's degree in philosophy from the University of Dallas with a focus on classical philosophers. And he has taught bioethics at UD for a decade. And our third panelist, Brigham Willis, MD, MED, graduated from UCSF School of Medicine, completed his residency at Children's Hospital and Research Center in Oakland, and finished his training in a fellowship at Pediatric Critical Care Medicine at Children's Hospital Los Angeles. He also holds a master's degree in higher education from Arizona State University. Brigham's many areas of interest include pulmonary cell biology, cardiac physiology, and medical education. And some of you will know him because up until last month, he was Senior Associate Dean of Medical Education at our very own School of Medicine. And then he sadly left UCR to become founding dean at the University of Texas at Tyler School of Medicine. So congratulations again, Brigham. Just a couple of words about the topic. What happens when we die or when we nearly die? The idea for today's conversation on the topic has its origins, at least on my part, in a book by John Fisher and Benjamin Mitchell Yellen with the title Near-Death Experiences, Understanding Visions of the Afterlife of 2016. And I'm going to share real quick, just for a couple of brief minutes, my screen with you. And this is the image from the cover of John's book of 2016. It's an image painting by Hieronymus Bosch, more than 500 years ago, painted around the year 1500. And as an art historian, I've been intrigued to revisit this painting on John's book cover. What we see is the ascent of the human soul to heaven. In other words, the process of human death as Hieronymus Bosch envisioned it. We could also say that what we see is a gradual disembodiment in several stages, the transition from earth to heaven. So what you see on the lower left is a naked human body cared for by two colorful angels with spread wings. And we need to read this as a sequence from the lower left going up into the tunnel. It's always the same body, human body. So we see it moved up by the angels on the right with open arms, getting ready for the journey. And then further up, smaller, gradually losing color. And then it's about to enter this perfectly concentrical tunnel up there, almost colorless. And this is where the angel leaves the body. And the body, the transition is made and the body walks through or moves through the tunnel alone by itself until it reaches the light at the end of the tunnel and then disappears into that light. And I'm going to take the image away at this point. Okay. So apart from this brilliant art historical reference on the book cover, I was also struck by the fundamental nature of questions asked in that book, such as what are the implications of the reports of near-death experiences for issues about the categorical nature of reality and about the relationship between our minds and our brains? Do those experiences show that our minds can function separately from our brains? Do the patterns and similarities in these visions, often the tunnel and the light at the end of it plays a key role, suggest that there is an afterlife, so deeply metaphysical issue? These questions have resonated with me as they resonate, I'm sure, with you. Today's roundtable also looks at the medical side of things, presenting the perspective of physicians. What happens in the moments leading up to clinical death in this gray zone of transitions when life hangs by a thread, an unclear space where decisions about what we consider to be life and what we consider to not be life any longer are based on scientific definitions that are not at all beyond dispute. What are the mechanics of death? What does death in an ICU mean? What are the criteria used to announce death? What are the typical responses? How is the approach to the diagnosis of death different from other diagnoses? And how is death measured? And when is someone really or only nearly dead? So, difficult questions. Please join me in welcoming our panelists, John William Brigham, and I'm turning it over to John Fisher. Thank you.
No, I think I have it unmuted. Thank you to the Center for Ideas in Society, and thank you to Jeanette for organizing and supporting this. I'm looking forward to it. I think, well, we have two physicians and one metaphysician, and I'd like to start with the physicians. And I am particularly interested in hearing about some of their experiences with patients in near-death contexts. What have they observed, and what kind of meaning can you get from those observations? What does it tell us about dying, perhaps about attitudes toward death, or even what does it tell us about the meaning of our lives. So we'd like to hear some of the actual stories. And we're going to start with a case, a famous case, Jahai McGrath in Oakland, California. And we're fortunate to have Brigham here, who trained at the institution which treated Jahai, or at least was, and Brigham, though he wasn't directly involved with the case, knows a lot about it. And I'm just going to turn it over to him to start focusing on that case, and that can be a springboard for our later discussion. So Brigham?
Absolutely. Thank you, John and Jeanette, for organizing this and having me here. It's a true pleasure. As you mentioned, I'm a pediatric critical care physician. So unfortunately, I've been part of many deaths of children and the process as it involves the family and these kind of things. And so I've thought pretty deeply about these things over my career. Have had a lot of experiences that have really shaped my thoughts about all the questions you were just talking about. The Jahai McMath case is a great example of a case that really calls into questions much of what we think we know about death and what it means to die even. And it seems like that's a simple question, but it really isn't. So in the interest of time, and we could talk about this for probably hours, but in the interest of time, I'll just summarize it really quickly. There was a adolescent named Jahai McMath who came in for a tonsillectomy, a relatively simple surgical procedure, to the hospital where I had trained. She hadn't really wanted the surgery. The parents kind of thought it would be good for her because she had various sleep apnea issues and would help her life. Underwent the surgery anyway. Relatively routine post-op care became not so routine when bleeding became more severe than expected. She had significant bleeding into her trachea, the big air pipe that keeps us alive, and it clotted. And when that happens, it's completely impossible to do what we do as physicians every day and put a breathing tube in and breathe for them. So the physician team was unable to do that. She ended up suffering irreversible anoxic brain injury, and so had severe damage to her brain. Horrendous outcome for a very simple surgical procedure. This led to her achieving the legal and clinical definition of brain death, which we can talk about later in more detail if we want, but every state in the US has a brain death definition where you are dead legally, that's sort of the key word, when you cease to have a certain level of brain function. Her family did not accept that definition of death, and it led to an incredibly protracted legal, social, community battle on what the definition of death even was, and who was right, and who had the right to decide when she would be taken off of, let's call it life support, right? And led to her being shipped across country to a place who would take care of her, what the doctors in California called take care of her dead body, which is interesting terminology that people used. But and eventually she succumbed to a number of years of being supported on mechanical support. So incredibly difficult case whenever you have that kind of level of conflict between caretakers and families, and it's incredibly hard. But for me, in terms of what we're talking about today, it really brought into stark relief how we even define death. I mean, up until a few decades ago, this would never have been a discussion, right? We're pretty clear on what death was. And so we're able now with technology, in my view, to maintain these intermediary states where it becomes fuzzy as to what even death is, and it allows us to talk about what does it mean to die, and was she dead or was she not? And a lot of different people can have different opinions on that. And I've had a lot of cases where that this whole concept comes into play. But that's kind of the summary of the case, and I'm happy to talk more about it later, but I didn't want to go too long just describing it.
No, thank you very much. And just to clarify, after she was legally dead, according to the brain death criterion, and the scans showed no brain activity of the relevant kind, she could still breathe and her heart was still beating with that. No?
No, so part of the brain death criteria that you cannot initiate any breaths on your own.
Okay.
And when you achieve brain death, you are kept alive by a breathing machine that breathes for you. However, all of her other sort of bodily physiological functions were working. Heart's beating, kidneys are working, liver's working, all those kind of things. She's just not, and her lungs work. The brain's just not initiating the breathing.
Okay.
mechanism.
And from the reports I've read, over time, her family felt that she responded to questions that, for instance, her mother or her grandmother might say, "Hi, raise your index finger," and she would do that, at least sometimes. Now, I don't know how accurate those were, and some doctors who investigated the situation thought, well, the response to the question happened fairly quickly after the question, so they thought maybe it wasn't a coincidence. But then again, I don't know how many times they asked her questions and she didn't respond. So are you familiar with that?
Yes, and this is actually not just in her case, but and William can speak more eloquently than I can on this, but there are a number of cases where brain death criteria may be achieved, and then there are later neurologic function that may come back to some extent. It's pretty rare. The brain death criteria are quite useful in a utilitarian way, and that most people do not recover function after it. But yeah, there are a lot of controversy about how much brain function you can recover, and how real it is, and how significant it is, and those kind of things.
And I also read that a doctor who was important in evaluating her in New Jersey happened to be a practicing Orthodox Jew, or at least a practicing Jew, who, and where in the Jewish tradition, there's a real emphasis on the breath and the idea that the breath is associated with life. Now, she had to be assistant in breathing, but he argued that maybe we shouldn't have this prejudice toward the brain.
Absolutely.
Maybe, right. So that was interesting.
Right. So it brings up to me, and I teach students about this in medical school a lot. Why and when did it become the brain that became the center of our definition of life, right? I mean, we know functionally it was in the 60s when we came up brain death criteria, and it was utilitarian. But for the rest of human history, that was not the criteria for death, right? Period. It was heart function, breathing. And so it's very different and very new, and sort of trying to impose that on very widely disparate cultural backgrounds is problematic at times. And for me, it also brought up the fundamental question we're talking about today is what state was Jahai in at that point? Like Jeanette brought up the question, how are the mind and brain even linked? Like, was her mind still present in her body? Was she in the light situation, like in that painting, or halfway? Or like, how does that work when someone's in that in-between state? So it's just fascinating to think about.
Right. And one of the practical questions is who gets to decide and so forth.
Right.
But also the issue of organ donation comes up, and you have to figure out when the individual has died before you can take the organs, or at least arguably. So there's a real practical implication of different views about when the death occurs. William, I want to give you a chance to jump in and comment on this case if you'd like, or just offer your own reflections.
Yeah, I think thank you, Jeanette and John, for hosting. I think this is a incredibly interesting, and if it wasn't so serious and sad, it would be. I think talking about these interesting questions is fun. The McMath case, I think, is kind of a capstone to this issue of why the brain. Clearly, all 50 states, the great majority of the world has laws around this, that if your brain is dead, you're dead. And then McMath was all this stuff sort of rolled into one, this, terrible, unexpected complications. And then that itself in the pediatric world is also sort of a metaphysical problem. Like, kids aren't supposed to die. What does it mean that the universe is instructed in such a way? This happened at a time of increasing social unrest. So she's an African-American woman who's taken care of by people of different races and genders, and that entered into this, and then the community sort of pushback entered into this. It was, all this stuff is sort of surrounding death, so it's never just an isolated organismal problem, right? It's everything. Then yes, so she ships off to New Jersey, and why New Jersey? Well, because New Jersey has all 50 states have these laws, but then there are these corollaries. So Texas doesn't have, Texas has no corollaries to its brain death law. You are dead when a physician declares you dead by cardiovascular criteria or brain death of the total brain. And that's kind of the uniform language. But then there's like 4 states, California being one of them, has this language about a due consideration or something. And so in the California code, there's actually like this pause. You declare them dead, but there's some due consideration. It doesn't explain what that is. And in practical terms, I think it just means, don't ramrod over people. But in New Jersey, it's got a religious exemption, saying if you say that I have deeply held religious beliefs that do not include brain death, then that law doesn't apply. Which to me, that's even a more interesting political question. Like, what does that mean? That you're dead to the world, but not to your religion? Or, I thought dead was dead. And so, I think all those things are sort of wrapped up in this. And then, what makes McMath truly unique was there's a series now that's kind of become appreciated that brain death is not what we said it was back in the 60s. And what that meant was this was a black and white. Now, once you're brain dead, you become disintegrated and things literally start falling apart. And so no matter what you did, you couldn't save them. And that was one of the sort of proofs of concept that, if life is sort of fighting chaos, then death is the admittance of chaos. And so brain death was, we said, the medical world, the scientific community said, maybe days, maybe some weeks if you're a kid, but it's inevitable, inexorable, irrevocable, right? And then what has come about in the last 50 years is, well, that's not quite so true, that there are cases where the organism clearly continues. That it grows. There's been cases where kids have had long-standing brain death, meeting criteria, but metabolize nutrients, maintain their temperature. They never breathe. They never react. They never have nuclear response. They never have any kind of signs of consciousness. And so brain death isn't as categorical as it once was, but everyone sort of agrees that there's no coming back. The McMath case was super disruptive because she may have done something. This is the flicking of the fingers, which would imply that she's in what's called a minimally conscious state, where you have some evidence that you're interacting with your environment, and that's never been the case before. Her situation was such that she lived in California, and then she went to New Jersey, and she was in New Jersey for like 5 years, and they wanted to come back. But in the United States, Medicaid or Medi-Cal in California, it's pediatric subsidized healthcare is state-based, whereas adults Medicare is federal. So because she was a kid, her state funding was state to state, and so California considered her dead. New Jersey didn't. So she could get Medicaid in New Jersey. She can get funding for her healthcare in New Jersey, which she required 24/7 nursing care because she's on a ventilator the whole time. She's requiring assisted feeds, that kind of thing. And so they wanted to come back, but she couldn't come back because she couldn't get funding. And so her case was about to go through the court systems, and then she suffered a GI bleed. And I've not been able to piece together what exactly happened there, but she had a catastrophic gastrointestinal bleed and died or had cardiovascular death. And so she actually has 2 death certificates, one from California and one from New Jersey, and they're 5 years apart. And I think that sort of speaks to, at one level, what is death? Well, death's how you identify the squirrel that's in my, my street here. That's obviously dead. But what is it to nearly die for a human being? There's you, there's your family, there's your society, there's your community, there's the laws, there's this history, and none of it is apart. It's all sort of wrapped up in one. And so I think teasing that apart of like, what is death? Well, what lens are you looking at?
Good. That's great, both of those. I'm curious, since both of you have clinical experience with dying patients, can you tell us, maybe we'll turn it over to Brigham, about some stories or your experiences or patterns. What do dying patients say, or what do they want? What do they need? Or what meaning do you give to what happens just before death?
Yeah, I can definitely speak to that. I want to make one comment about something William said and just agree really strongly with him, that disintegration concept, right? So it speaks to the soul or the mind or whatever you want to say. What is it that keeps us keeping chaos out, right? And it's not sort of neuron connection function, right? There's something else serving that integration function, and what is it? And like Jahai's case, as William so eloquently said, kind of brought that to the fore, right? She sort of disproved this theory that if your mind was gone, your brain was gone, you wouldn't be able to hold things together. And there's more than just Jahai's case where you see that integration maintaining even though brain function is gone. So what does that mean for when you're nearly dead like that? What is maintaining that integration function in some people, but in others it doesn't, right? There are a lot of cases where I've seen many cases where when you are brain dead, it rapidly devolves. Every single organ system falls apart. So the integration function has gone. And so what's the difference between those two? In terms of your specific question about, experiences like near death and what patients go through, and what I think about is how the mind or the soul or whatever sort of interact with physiologic function, right? Because me and Williams talked about this. I'm a scientist. Us as medical doctors, we're trained very scientifically, and how does the physiologic function get maintained? But a case that I had that kind of really made me think about that hard, and how maybe it wasn't just science, or I didn't understand enough about the science at least. I had a child who was about 6-7 months old and had struggled with a very severe congenital heart disease, born with this type of heart disease that was unfortunately not surgically correctable and progressive, where the veins, explaining the anatomy takes a bit, but the veins draining the lungs actually just progressively constrict over time. And and there's nothing you can do about it. And so the child was basically smothering over a long period of time and having progressive difficulty breathing. But an infant, right, a 6-7 month old child who couldn't speak and couldn't do anything. And we were waiting for, the dad was there with the child, and they understood there was nothing we could do, and it looked like it was going downhill. And the mom was not there, and she was trying to come as fast as she could to be with the child before death ensued. And I'm watching the dad with the kid, and the kid's like looking at him and is just struggling to breathe, and has this look of like terror like the whole time. And we're trying to give drugs to make it, but if we give too many, then the child will succumb and the mom can't get there. It's a very difficult situation. And I remember the moment, like it was yesterday, the mom walked in and picked up the kid. I get like teary. And the kid looked in her eyes, smiled, and died, like instantly. Like the heart just stopped. And William knows it's not normal. That's not a normal way for a child in respiratory distress to die. Usually they keep breathing hard, and maybe their heart will slow down and things kind of progress kind of slowly. But it happened instantly. Like I swear, I've never seen anything like it. Like the heart just stopped after the kid. So that for me was a great example of like, I don't know if I understand the integration of the person with the organism like I've always assumed I did, or like I've always been trained, right? I still have no physiologic explanation thinking about like electricity or oxygen or anything for how that happened, right? And so that's one example of things that have happened where I think there's some level of this integration concept that William spoke of, that it's a lot more complex than I think we as scientists sort of understand it.
That's an extraordinary, very sad story to me, but extraordinary. If I may follow up, have you had any other experiences like that where you've seen either children or adults as they're dying have a kind of peaceful look on their face, or almost, yeah, a serene, happy demeanor.
Yeah, I definitely kids for sure when they're interacting with parents. I've seen that. Had a couple of kids who had long-term cancer when they were finally let go. It seemed like it was a kind of acceptance moment. I have to say the opposite. I remember I had a 17-year-old who had Duchenne's muscular dystrophy, which is a progressive muscle weakness issue, who they generally progress where they can't breathe very well for a while, then their heart fails after a time. And he kept having his heart stop like multiple times over this multi-day period. And we kept having to do chest compressions, and like the medicines were stopping to work. And it was such a weird experience though, because in between dying, right, his heart would stop and we would revive him. We'd have these conversations about, do you really want this? Like, this is not going to work long term. We don't have any options. And we figured at some point he'd be like, let me go peacefully. It's going to be, good. And he was incredibly insistent that we keep doing that, because he kept saying, I've been over that line a few times, and he kept saying, there's nothing there. He kept saying, it's black, there's nothing. And so there's like, I see these cases where they seem like they're ready, and it's that, then there's that. And so it's like that. I've seen both, I guess.
Right. That's interesting.
Yeah.
William, how about in your experience or further reflections?
Yeah, this so like Briggs said, I'm a trained scientist, right? And I have some training in philosophy, but I think my basal disposition is scientific, and so I really want a mechanism, right? I want a formula. Like, so this integration thing is super appealing to me, but even more so, that what I really want is the formula for integration. I want to know how to measure chaos, and then we could have some coefficient of chaos, and I could say, okay, that's when you crossed over, right? And for example, one of the examples I give about brain death, for example, just a couple of years ago, I had two patients actually side by side in my unit. One of them was a 3-month-old who had a bad congenital malformation of her lungs and had super high pressures in the lungs and needed to go undergo surgery to fix something, and had this catastrophic bleed, had bleeding on cardiopulmonary bypass, so bled in the lungs, but then also bled in the brain. And the baby was like 3 months old, and it was a long surgery. Came out of the OR. In those cases, they're hemodynamically unstable, to begin with, and so they didn't actually quite recognize that there had been this catastrophic brain bleed, because it's expected that your sort of hemodynamics are your blood pressure, your heart rate, that kind of thing are going to be abnormal. And so then several hours after the surgery, things aren't going as planned. They're not waking up, and then come to find out they had a brain bleed, and a terrible brain bleed where the brain is being pushed over and significant amount of pressure. Surgery was done to take off part of the skull to relieve pressure. And then, then they come to my unit to where we're trying to do traumatic brain injury treatments, prevent this from going any further. Next to him, so he was admitted on Monday or Tuesday or something, and then things just get worse and worse and worse. He's progressing down towards brain death, where there's no reactions, there's no breathing, that kind of thing. Next to him, then I admitted a 12-year-old who had a self-inflicted gunshot wound. And he had basically blown out most of his midbrain and his cortex. And he comes in, and he's, as it would have, just parked right next to my other patient. And he also quickly looks like he's progressing towards brain death. So, not conscious, not breathing, no reflexes, pupils are blown. And I'm on call this night, sort of taking care of both of them. And this 3-month-old is tragic because it's a 3-month-old, and all the family have gathered, and we've been doing all these heroic measures, and I have to tell them this is not going how we want it. I don't think they're going to survive. But I'm not having to do a ton. I'm not having to like tinker with a lot of the medicines. It's I get called for occasional problems. I go by and I check things, and most of the numbers are sort of in line, right? Whereas this 12-year-old, from the minute they get to the door, I'm just constantly going back and forth, adjusting different blood pressure medicines, giving volume, giving medicines for abnormal salts, that kind of thing. And it's all night I'm having to do this on this 12-year-old. They both then meet criteria and then progress, and we go through our sort of institutional ways of declaring brain death, and they both are brain dead. But one was just chaos the entire time, and actually I was working to get the numbers sort of normalized enough that we can actually do the exams on this 12-year-old, and peeing too much, not peeing enough, blood pressure high, blood pressure low. Whereas in this 3-month-old, I didn't do hardly anything other than to say that this is irreversible and it's not coming back.
Do you think when you say you're a scientist, you want a mechanism, is the idea that so far we just don't have a good description of the mechanism, but you're betting on science. You're not betting on metaphysics as though there's a soul that's doing the integration. Or you think that in the end, it will be describable as a scientific mechanism?
Well, yeah, I mean, I also know that's my bias, right? That I like formulae. And what I think from the sort of the integration perspective is that if there is a hole, and it does seem like there's a hole, that the 3-month-old seemed to still be whole despite not having any brain function. And the 12-year-old did not seem to be whole. He seemed to be parts. And the problem, I would push on a part and then some other part would fall apart.
Mm-hmm.
And so what's that wholeness? And where would that be?
Right.
What organ controls wholeness?
The body is so complicated, and so maybe there are nuanced differences between the bodies of some who remain whole after brain death, but maybe it is something kind of beyond the body as well, as Brigham suggested. Are there, one thing I'm curious about is, okay, some people are serene and have a smile perhaps as they're dying, and other people are fearful, angry. Do you have any reflection on what makes the difference? Because you might think, the people who believe in an afterlife, and they are pretty confident they'll go to the good place. Maybe they're going to be serene. But that young baby was just how old? 3 months, 6 months. They didn't have any idea of an afterlife. So I don't know. Do you have any reflections on what makes the difference?
Well, just to link this back to the integration question. So those are the data on long-term brain death. This is a phenomenon of kids, that the older you get, and older meaning 20s, beyond your teens, chronic brain death isn't a problem. That really there are not. I don't know there's any cases above 35. I'm sure that the vast majority of these cases where you have humans that persist while diagnosed with brain death, it's a kid thing. And I think that's an interesting problem. Like, what is it about? It's not just coronary artery disease. And we know this is Brig and I are pediatric intensivists, and one of the reasons why we're pediatric intensivists, not adult intensivists, is that adults are trying to die, kids are trying to live, and I like being on the winning side. And there is really a difference between kid disease and adult disease. And it's not just that, they haven't been eating McDonald's as long as the other ones have. There's something about the bodies. And so I wonder then, layer that on top of then understanding, like my 5-year-old is starting to ask a lot about, questions about life and death. And he's at the age where whatever that, developmental process is, where you can start to abstract into nothing or infinity or after. But before that, what does a 3-year-old think about death?
We've raised many questions that we're not going to be able to try and answer, but we've raised them and we can think about them more and people can chime in. But I have another direction I wanted to go in. What do you tell the parents of a child that's dying? Or my son is a medical resident at LA County USC, and I asked him, he sees, unfortunately, a lot of dying patients. Well, what did your professors in medical school tell you? Did they train you? And he said, no, they didn't say anything. But what do you say? And is there, how do you decide how to deal with this so humanly difficult situation?
So I can jump in on that. Yeah, so your son's experience is what I went through. No one talked about this when I was in medical school. And so I've made it a huge part of my career trying to change that. And so I ran a course in my critical care course. There was a lot of training on sort of how to talk to people about death and how to do that. Because it's stunning that we took a long time to put that into medical education curriculum. It's maybe one of the most important things we do as physicians is talk to people about death and how to do it. And I don't have any specific words to say, but I can tell you what I think is the most important thing is being transparent, direct, empathic, and firm at the same time. So giving them information they can tell they can trust and doing it in a clear, direct way. One of the biggest problems when you're talking to people about death or severe injury is talking around it because you're afraid of it and you don't want to, you're afraid of giving the bad news. So a great example I use with students is you have to use the word dead. Like when you're telling families about what has happened, because lots of physicians want to say passed away or isn't with us or all these euphemisms, but things like that, being very clear while maintaining the empathy, right? Maintaining that connection where they can tell that you understand the gravity of what's happening. I actually made a series of videos of good and bad ways to do this. But I think that's the key thing is not being afraid of the topic and talking about it in a human way, but in a direct way. But I don't know, William, with you.
William?
I agree. I think, words matter. One of the ways I do have questions about this, right? These, what is death? What is life? Those things, they're rattling in my head, and I'm academically interested in these things. But at the same time, me coming in there asking metaphysical questions while their child's dying would be injurious potentially, right? And so I think a lot of how you die in an ICU, to me, unfortunately, a lot of it is performative. That so much of what's happening here is I see where this is going. I'm going to do the things we can, but a lot of what I'm doing here is so that you, the family, come to grips with what's going on here. And
there was actually a question in the chat about that, about is what we're doing to dampen down the process of death so that the living feel better. But
oh wow, yeah, right. I mean, no, that's a thing. I see that now. Strong painkiller cocktails like to mask it. Oh, absolutely, right. And who's that for? And so, I think walking with people, being there, knowing when to say something, when not to say something. But one of the things that I'm terrified of, right? So you're dead when I say you're dead. Like that's actually the law, is when a physician declares you dead, or someone appointed by the state declares you dead. That's when you're dead. And so in a very real way, this is, I honestly, every time I declare somebody, there is a bit of like terror that, okay, they're gonna like pop up, and that's a known phenomenon too.
I thought that was just me that I was terrified of that.
You trained me, so maybe you just downloaded your fears. It's called the Lazarus syndrome, and it's a known phenomenon where probably it's a release of endocrine hormones or epinephrine, and you restart the heart for a bit, and they jump. And so when I go in, I'm an ICU, so I have all of these monitors, and typically I know where the heart rate is, I know where the heartbeat is, and so I go in when I'm clear that I wait till no electrical activity besides just no cardiovascular pumping activity, and so then I examine them. I put my stethoscope on, and I place my stethoscope on the chest. I'm listening for nothing, and I listen for some period of time. And depending on where I'm at and who I'm talking to and how close we've gotten or how resistant they are to the tragedy that's come on their lives, I may look at my watch, I may whatever, right? But then I tell the nurse that she or he died at 3:18, and so I try to maintain this sort of clinical, but like give the word they're dead, because I think empathetic and firm, I think is a great description of that.
Yeah, that's a fine line, isn't it? To thread the needle between.
Just to yeah, build on the performative nature of it is actually kind of important, I think. Like when patients die in my unit, they have a million monitors. I know, and usually I wait for a number of minutes just to make sure exactly. So me going in and listening and feeling the pulse, it's totally performative. Like I already know what's happening, right? But it means a lot, right? It means a lot to have that ritual almost, right? That process with the family to, I don't know.
Well, could you imagine a situation where like you didn't do that? Like, I know from the monitors when they're dead, I think, right? And so you can imagine like I could text the nurse saying died at 3:18. And what kind of environment would that create? I mean, that would
I know with adults, almost always in dying, they don't want to be alone. They want to be with their loved ones. How about in the case of very young people? I assume for the family, it's incredibly important for them to be there. And I assume for the kids as well, if they're old enough to understand. But can you comment on that? I know that for adults, having a companion or loved one there is extraordinarily important. And in near-death experiences, which we haven't really got into, but often the story that people report is one of accompaniment by loved ones, reunited with deceased loved ones and going together toward a light or an otherworldly realm, perhaps. And I think the same thing happens when people are dying. They want to be accompanied. Do you find that as well?
I think 100%. I think that the case I was talking about, to me, proved that. I mean, that child was wanting the accompaniment of their mother to allow them to peacefully die. That's what that seemed like, right? I mean, I can try and come up with physiologic reasons where they, I don't know, had a jolt of epi or something when the mom got there, but it doesn't make a lot of physiologic sense. I'd have to talk around it, right? But I think I've seen that with lots of babies. I mean, that connection with the mother starts in utero, right? I mean, it's incredible. We can see physiologic changes in children from looks from their mother's face. I mean, there's so I think that accompaniment is really important, especially when there's that's happening.
To me, it's a continuation of what we see in life, right? That you can use less pain meds when the mom is there, right? And there's all these, and touch, like, that was a revolution in the neonatal ICUs. Was it's called kangaroo care, and you put these little micro babies on top of the mom's chest, and they grow better, like, so it's we're wired for this, we're built for this, and so to me, as the sort of wanting the formula for it, that makes sense at the end, but it does seem like death is never just of the organism. It's of this. There's a relationship that's also dying, and I think that's present. I don't have any wild stories as wild as Briggs, but I see that all the time where these deaths go really much better if there's touch and connection.
You both are primarily working with young people, children. I understand that. I mean, among adults, let's say, some people have more peaceful deaths and some people have more violent or angry deaths, you could say. I don't know if you have any reflections on those differences. My son has also reported, I mean, he's been working during COVID times, and he has to facilitate communication between the dying patient and the family or loved ones sometimes via FaceTime and so forth. But what he says is nobody's ready for death. Nobody's ready for death. And I sometimes wonder if that's mainly because he's working with COVID patients who've suddenly got ill, and whether people who have time to bring their lives together and make sense of them could have a more peaceful death. But I don't know if you have any comments on that, just the philosopher's ruminations.
I can jump in. I think we're biased, William and I, because when a child dies, it's always out of the natural flow of things. And so being ready for that is almost never the case, right? It's something completely abnormal in the worst day of their life. However, I can say families' acceptance, once it's become clear what's happening, is wildly different depending on I don't need, it's hard to even say what. I have seen no correlation between religiosity and acceptance of death. I think atheist families become just as accepting as highly religious and vice versa. I think it's something internal and just how your feeling is and what your relationship is with the concept. But I don't know, William, if you.
That's very interesting. Yeah, I think in a way, some atheists feel my suffering will be over. My child's suffering will be over. And therefore they could be at peace with it. William?
Yeah, Plato has Socrates say in the Apology, where Socrates is sort of getting ready for his death. To philosophize is to learn to die, and that's a big part of classical philosophy. Is this the ars moriendi, the art of dying? And the world used to be filled with death. I mean, there was just death everywhere, right? And that to me is the marker of modernity, is when we can actually do something about that, and that changes everything, right? And so, Brig and I, we work in this ICU, and that's what is an ICU if just the consolidation of technology, and much of that technology is to prevent death, to stave off death, to give you some time while you heal on your own so you don't die, right? And I think our environment especially is it's hard. It's hard to die peacefully in an ICU, because there's so much we can now do to you.
Right. I think now there's a movement toward more humane ways of treating people who are dying, in hospices, Zen hospice at UCSF and so forth. But yeah, there are cases where that just can't be done. Last question before I turn it over to Jeanette to moderate questions from the group, and you're welcome to jump in the chat. How do you, for you, it must be very painful, must be very stressful, must be sometimes very sad. How do you do it? I mean, how do you stave off the depression and the frustration? What do you tell yourself about what you're doing? So, Brigham?
That's a really good question. I can just speak from personal experience that it's hard. And if you don't, in a proactive way, try and stave off bad consequences of dealing with a lot of death, it can get to you. I went through a period in my career where I was very burnt out, actually got diagnosed with PTSD by a therapist, and have had to deal with that, because it's a hard line to walk, being empathic but not too empathic, because when you get too connected and too empathic, it's personally painful every time it happens. And there's no way to actually avoid some element of personal pain in what we do, because you feel like you failed every time someone died, even when it's expected, even when it's like the best thing for the patient. It's hard to avoid this feeling that you failed in some way, right? So that is, for me, was extremely difficult to deal with. To get over that, I had to sort of engage in a lot of therapy, but active focusing on the positive is what I do, because it's too easy to always focus on the difficult cases. And so a lot of focus on gratitude, and I have a picture board of the patients I saved right here, having that in front of you every day, like focusing on the positive of what you do. But it is incredibly hard to maintain that connection with your patients and not end up either totally unfeeling or broken.
Great. I appreciate that answer. I noticed that it's time to turn it over to Jeanette, so I will do that. But if William, you want to say something really quick, go ahead.
Yeah. So we talked about performative aspects of all this before. That's not to say that the performative aspects are superficial or unnecessary or fraudulent. I think one of the things that's gotten me sort of understanding all this is that really this is like one giant narrative, and it's a story, and I'm playing this part in this story, and I think the story actually does go somewhere, and my role in that story is to play the best part I can right now, and that includes taking care of parents who appear high while you meet them for their kid that they say just fell off, whatever, and it's more than likely non-accidental trauma, and they were the abusers, right? And so in that situation, I have to be the good doctor in the same way that I am with the parents who have a 7-year-old who's diagnosed with some terrible inoperable tumor, right? And so my job is to make this as meaningful as it can be for them, so that they're not wrecked by this. And those are wins, when someone can have a good death, that's a life narrative changing event.
Because one thing about narratives is the ending is very important. That's the crucial thing about a narrative, is you understand the whole thing in terms of the ending. So Jeanette, I'll turn it over to you.
And sometimes you only understand the narrative, or most times from the end. So I have to apologize, because I think I had some noise disturbance in this earlier. I don't know how bad it was, but I'm sitting on Palm Desert campus and there is something going on that I'm not aware of. So yeah, thank you all. This is, it's so fascinating. And I kept thinking about the idea of silence in, with the mechanics of death in the end, because, there's chaos and there is a lot of noise, probably a lot of times. But I remember in one of the emails that William sent earlier, there was a lot of, silence was mentioned a lot of times. And I was wondering, William, if you could tell us a little more about the role of silence in death, or, in those situations.
Yeah, I think that's about this narrative again, in the lens, I guess, so silence can be comforting. Silence can be, finally it stops. Finally the noise and the chaos is done, right? But silence can also be the void, the nothingness. And yeah, I think silence is disruptive, whatever it is, because we're social and communicative, and we have all this sensory input, and so I'm a talker, and I'm a fast talker, and I want to get a lot of information out, but I'm very cognizant of that in these times with parents, especially, of letting that sink in. And then I want to talk, but I know that I need to wait no matter how long that is. And that's one way of moving them to acceptance, moving them to what's going on here is, I've told you this and there's nothing else to say, because I can't make it different.
Funny that, just to jump in on that, about the notion of quiet and peace during the death process. There's a question I saw in the Q&A about what is it, and we know it when we've seen it. I've seen a lot of death, hundreds and hundreds. And if I say what a good death looks like, it's peace, it's quiet, it's peaceful, right? And there's a connection, what John was talking about. There's accompaniment, right? So that is what I see as a good death. You're accompanied by loved ones. It's peaceful, it's quiet. That's what I see as a good death. And the over mechanization and technical aspects of death that have happened in the last 50 years only, I think are, to some extent, somewhat of a disaster for our species. I think we've lost this connection with death. We've lost this ability to even accept a quiet, peaceful death like that. It's always do as much as you can to preserve kind of any kind of life for any period of time. And I think we may need a reckoning with that as society, that that's not what we want to be, right? To be just completely technologically dependent at every second with a lot of chaos and a lot of noise at death. I think a good death is kind of the opposite. This is a little bit of a joke, but having been through so many of these and trying to have some idea of what a good death is, I say I'm going to have one tattoo on my chest, and it's going to say I did not sign the consent, because I don't want all that. I don't want all that that technology and stuff for when I'm when my time comes. So.
Mm-hmm. And
I think we can learn something not only about dying, but about the meaningfulness in life, because I think the most important thing about a meaningful life is connection to other people, to colleagues, to loved ones, to family, to something bigger than oneself, whether that be a God or an ongoing activity like science. But we think of meaning as coming from connection. So it's not surprising that we want that in dying, and also that we, in our near-death reports, we conceptualize them in terms of accompaniment and connection.
That, leads to the question of life at all cost, which would probably merit another round of what we're doing here today.
And one of the horrible things about that is we lose our connections. We're just in a sterile hospital room, maybe with a connection to a feeding tube. Yeah, we lose accompaniment with loved ones.
I wanted to come back to the question that Brigham kind of touched upon earlier. Amir Itzhaki writes, Alan Watts, in one of his many wonderful talks, discusses the fact that death, like birth, is incredibly violent and intense, and that we in Western culture try to do all that we can to dampen down that natural process of death in order to make the living feel better. We give strong painkiller cocktails to try to mask the natural process of death. It's only because we have a delusional idea of what death means that we have developed these sterile, and that what keeps coming back, practices. Any thoughts, question mark?
Yeah, I think the violence, I think, is also there's two sides of the same coin of this technology, right? That so much of the modern age, so much of modernity is about tamping down violence and manipulating nature through the use of technology for our betterment. And so I think this is all wrapped up in a piece that, when doctors couldn't do anything, what could you do? We could hold hands, right? And we could prescribe dietetics or air or walks. But really what your doctor could really do was be there, with you. But now then the doctors can do something, then, I think about your tattoo, Brig, and I'm just thinking, okay, what if you're just like little V-fib, and you'll be okay, or you inhaled a peanut and I just need to get it out, right? But so there, we'll accept some violence if it can do something. And so I think that's this idea of you're not going to die well if you didn't live well, and you have to, and living well will help you die well, and coming to terms with our limitedness and the limits of what we can do and what we ought to do, but then also at the same time is our vision and the abilities we have and what it takes to flourish. I think all of that requires more thought than I think we currently are allowed to have in 2022.
I think part of a good death would be an honest death, and there you have to be connected with the tragedy and also the beauty. And what I would say about the question is, I distinguish between a peaceful death of the sort Brigham was referring to and an anesthetized death. You might think anesthetizing someone will create the relevant kind of peace, but no, it's like the peace in meditation where you're active in a certain way, you're reflecting what's going on in an honest way. That's what I would consider peace, but not anesthetized.
I have another question, Wesley Lockhart. Can you talk about the discussion that goes into DNRs, advanced directives, as a physician to a patient or family? How do patients and families deal with death if those are in place?
I mean, I think the most utility of a DNR and advanced directives, and William could correct me if you think I'm wrong, is just having that conversation beforehand to get people sort of thinking about what they want and how death should happen. I've seen innumerable DNRs get discarded immediately when something actually happens. So I'm not sure the value of the paper is that strong actually, but I think initiating those discussions and having people start thinking about how do I want my death to happen is really valuable, and getting the family to start, it's the acceptance phase and actually building connection between family members before this starts happening.
We pride ourselves on being an evidence-based profession. So what are the data on DNRs? And if you peel this back even just a little, you realize, so Briggs, example of innumerable numbers that have been discarded. I mean, that's actually the data. The data are that there was, depending on where you look, but I could cite one that's, over 50% of DNRs change depending on, when you ask and who you ask. Even better is, so there's a study that looked at, people that were readmitted within like 2 or 3 months, and they had a DNR on the first time. Did they have a DNR on the second time? Does it say the same thing, right? And so over 50% of the time, it changes. They either had one, now they do. They had one, now they do not have one, or they didn't have one, now they have one, right? Then they ask, different study, when you made your DNR, what did you decide? And then you look at what they actually did decide, and over 50% of the time, they decided the wrong thing. Like they don't even know what they decided, right? And so then you say, okay, well, what if, okay, they're, people who have DNRs have bad memories, maybe that's the thing. Ask the person that's in there with them, what did they decide? And they also, again, are all wrong, right? And so, I think it's a situation where no one's ever died before. And so asking people to make decisions about when you die is a situation where you're asking them, is that informed consent? Do you really have all the information necessary, seeing how you've never actually experienced that? I think that's an interesting question about DNRs, but I think it actually gets back to John's point, is what really the DNR is communication, and you're connecting with somebody else, having these questions, because the amount you can avoid thinking about death as a member of our species is really impressive. People who are obviously about to die and have not thought seriously about this. And so maybe that's the utility of a DNR, but actually being like a contract, I think is problematic.
Quick anecdote, I promise. Quick. My dad was also a physician. I mean, I guess I'm the black sheep in the family. Yeah, I'm the black sheep doctor. And he kept, after he retired, he had his medical case, and he had something in it that would cause his death. He told us about it. I don't know what it was, morphine or whatever it was, and just in case. And he even showed us on his insurance policy the clause that says if the individual takes his own life, then it's still valid. Then at the end of his life, he had stomach cancer, and for years he was in a lot of pain. And toward the very end, he had to have a lot of pain medicine, but he never took that. He never took that. It was really striking to me that when it came down to it, he clung to life.
Thank you for sharing that, John. I have a question before I move on to the others that I see here. So we were talking about the importance of connection, of human connection, and I've always wondered, you as physicians, what role does intuition play when you look at a patient? I mean, you know what to do, you're trained to know what to do. There is a lot of procedure, a lot of, exact steps that you need to follow. But do you sometimes have a hunch, for lack of a better word, when you see a person, when you see a body, that you intuitively think this is going to work out or this is not going to work out? I'm just wondering what if there is that connection between physician and patient that brings a dimension that is hard to explain in terms of, I knew it. I don't know if I'm making myself clear, but I knew this was not going to work out. That type of intuitive reaction, what role does that play? Or can you tell us something about that?
I mean, on this one, I might plan science to some extent. I actually teach a course in clinical reasoning, and we talk about how experts make decisions. And intuition, if you really look at the data and the research, is really expert opinion, being able to judge a situation. And you can't even elucidate the reasons you have. It's just the situation because you've done it for thousands and thousands of hours. And I mean, I've had that happen many times. A couple of times, patients come back, they look fine. I tell the fellow, this is not going to go well. And you can't even elucidate exactly what is your reason, but you have an intuition about it. But I think it's mainly expert. You've seen so many cases and so many things, subtleties about what's happening that you couldn't even enumerate or speak of, sort of lead you to a decision. So I'm not sure if that's a connection thing, and sometimes connection might, I guess, throw off your decision making because you get a little bias potentially. But I think the intuition has to do with vast experience in most cases. I don't know, William.
Yeah, I agree. But at the same time, I mean, every death that I am involved in, I can't tell you which ones are going to be fast or slow, right? Like and I think it's a kid thing again. I mean, because parents want to know this too, like how long, right? Especially if you get into some of those conversations with people, if we withdraw the ventilator, how long will it take? And again, so you see previous comments about me wanting formulas. I would love to have the formula say it's going to take 15 minutes. But I've been surprised where it happens so much faster than I thought it would. And I've been surprised, like, oh my gosh, this is taking forever. Like, why, so I 100% agree that yes, there's these expert sort of habits and your ability to take in information that you may not be able to quantify completely. And I've gotten better at that. But I'm still just perpetually, flummoxed as well. Like, I don't know why that happened. I'm going to respond to it. I'm going to try to anticipate it, but I don't,
So the level of resilience is not really predictable in that sense that you say.
Yeah.
Okay. Yeah,
I agree. I've taken to saying, they always ask, once you take the tube out or turn off the medicines, how long will they stay with us? And I say minutes to weeks usually. It's like, I have no idea. It depends on so many things. I mean,
yeah.
Tough. There's another question about, kind of silence or not. Anecdotally, Brett Hyman, anecdotally, I've heard that those families surrounding an unresponsive patient, perhaps on life support, are encouraged to speak into their ears or hold a phone call from a remote loved one. Do our panelists have any take on this? So is the sound of a voice something that helps in those situations?
Yeah, I think there's something to touch. I think there's something to sound. I mean, like Brigham was saying, we know that infants recognize their voice, recognize non-human voices, respond differently to other babies' cries versus a mechanical cry, from like day one. And so, I think that's all part of our makeup. And so that, especially when it comes to what can they hear or feel or understand, that's where I allow, some space between what I'm doing as a doctor and what I'm, sort of as a human being. That, as a doctor, I'm a scientist and I'm an expert on biology, right, and physiology. But I also recognize that all this stuff that's happening has got all these other meanings to it. And so I don't know what they can hear, but I also know that that this may be meaningful or it may actually be helpful. And so I say, we should assume they can. And so and I think that brings comfort to everybody. But it allows me to also kind of a distance that says this is the edge of what science can tell you, and there may be stuff out here. And I'm not discounting that or saying it's not true. I'm just saying I'm not expert there.
I just agree 100%. I mean, it's that whole, with jihiving math, right? The case we talked about. I mean, I think even if science and society said she was dead with brain death, I would have been highly encouraging a family to be there and connect to who knows what that integration concept is or what. I mean, I think it requires, there's a real need for humility. The limit of what we know as scientists is real. We don't know that much. And so understanding that, I absolutely think that kind of connection is important, even during death.
Thank you. That's an interesting one. Do you think it could be possible to shock brains back to life, as it were, in cases like Jahai's in the future?
This one I could speak on with science. No, once the brain is irreversibly damaged, you get disintegration and dissolution of the neuronal connections and functions. So there would be no sort of easy way to restart a brain that's been damaged like that. So unfortunately, no. I wish that would be awesome, but I don't think that's possible.
Yeah, the longest case, there's a case series that looked at a meta-analysis of prolonged brain death, and it was published in 1998, and there was still a survivor in this cohort of patients that were identified. And at the time, I think in 1998, the patient was like 14 or something. He ends up dying another like 5 years or 6 years later or something. He's 18 or 19 when he died. And then they published the autopsy findings from him. And he was a poor child who at age of 3 had a bad Haemophilus influenza, meningitis, and basically pus and bacterial infection, ate his brain. And then he was unstable, then he stabilized, and he lived for 15, 18 years while brain dead. And when they did his autopsy, they found a hard calcified mass in his skull. There was no neuronal elements. There was nothing alive. It was calcium. It was rock. And he somehow was able to be integrated, though, for there was nothing there. And so that's why brain death has such appeal, is that if there's nothing there, then there's nothing to mediate the activities of the brain. The problem is that is integration necessarily one of those? And that's a whole other set. But yes, if the brain is gone, like any other organ, if you've taken out the liver, there's no liver to regenerate.
I think another reason why the brain criterion appeals to people is that's how we judge whether someone's the same person, or personhood is connected up with continuity of consciousness and values and memories. And when they're all gone, you think the person is gone. So you have the death of the person. But then it raises the question what the relationship between bodily death and death of the person is. But I just think people are attracted to the brain criterion just because of the importance of consciousness and values and memories for what we care about in relating to someone else.
Right.
Here's another one. Have you had many times, this is about miracles, as a matter of fact, have you had many times where you expected death, but the person rallied almost like a miracle?
I mean, if you're talking about brain death, no, but yes, like I became more and more humble over my career the longer it went on, because I think we were talking about how long kids last even when they're dying, but also the number of times where kids got better from stuff I didn't think they would. I mean, being a pediatrician, you're a little at an advantage because kids are trying to live and adults are trying to die. I love that quote. It's true. But yeah, I just became more humble about predicting outcomes. Kids are more plastic. They're more able to recover from stuff. It's pretty impressive. I mean, the word miracle is strong, but as in like someone I never thought would make it from a terrible bout of sepsis. And I've had many talks with the parents, and yeah, I've had people make pretty impressive recoveries.
Yeah, I think and that's why we're in this business is that kids do well. But I've had several patients that have gotten through, but then that's this temptation back to technology again. Like the ones that immediately popped in my head were kids we did a ton to, and so on one side I'm speaking that technology is this way that we make death violent and we tear up people. On this other side, though, this is what I do day to day. We use technology, and I've got several instances where it's amazing how well the kid did after all this technological intervention. So I think that gets back to the expertise and the prudential judgment that has to be part of it. But then that gets back to why it's so painful for doctors too, because I'm expert, but I'm humbled by my experience, and I think this is what we ought to do, but I'm not 100% sure. And sometimes it goes poorly, and so you feed on the great side, but then you also have to know that not all of them survive, and that's your job, is to help people work through how do we know what to do when.
Yeah. I love the quote that from Brigham's experience, kids are trying to live and adults are trying to die. And to me, that has two components. One, physically, I mean, the kids have the resources, you could say, to fight off the threat. And adults, as we get older and older, we have fewer of those resources. But also, how about the mind? I think the will to live, at least anecdotally, plays a big role among adults who are very sick. But the kids presumably all have the will to live, or they haven't been jaded by life. I don't know. Are they? What do you take the meaning of that saying to be?
Well, I stole it from William. That was his saying earlier. But I 100% agree. That's part of why I went into pediatrics. The beauty of the hope and the resilience of children is stunning on a daily level. Kids with brain tumors and leukemia and their hair is falling out and it's a mess. All they're wanting to do is go play with their friends and like get back to the connection. They're not like, woe is me and what's wrong. Like it's all just about like, how can I get back to being human and experiencing that connection you were talking about. And actually it speaks to, there was a question in the chat that I thought it was short, but very important. What's the point of life if death is inevitable? And that's like the base question of humanity, right? Why are we even here? I mean, that's the question, right? But I think I have some perspective on it now, and it goes back to that connection. Why are these kids who are facing life-threatening things just trying to get back to connecting with people? Because that's the point of life, right? Doing your best and connecting with people in a meaningful way, such that you have an effect and a meaningful connection with your fellow humans. And when you think about that, it doesn't matter how long your life is. Like the length of your life has nothing to do with the quality or the amount of connection or the effect you can have on the world. So that becomes then a beautiful part of life and has no bearing on the beauty and the quality of your life. Quote a little Whitman, I think you sort of paraphrased earlier, William, the powerful play goes on that I might contribute a verse, right? That the play will go on forever, but you have your verse and it's connected to the tapestry of the entire play. And that's the beauty of life. And it has no bearing on whether I die tomorrow getting hit by a bus, right? I've still connected and played that part. And a child who's one week old, who might die tragically, could have the same connection and could have the same effect on people. So that I think that's the point. That's how I think of the importance of life.
There's the Catholic Church has thought about this question pretty deeply, and one of my favorite sort of understandings of the good death is this medical relationship. So why is it that we get sick, right? Well, one of the reasons you get sick, there's the whole idea of the fall and fall from grace and that kind of thing as kind of as a punishment or a consequence of, right? But a more positive view of that is that you get sick so people can take care of you. That you get sick so that you are humbled, that we have these two poles, right? We have this one pole where it looks like we're gods. Like we every environment we're in, we terraform, right? As soon as the Aborigines showed up in Australia, like 90% of the ecosystem died. I mean, just we're amazing creatures, right? And then on another pole, we're awful things, that as soon as the Aborigines get there, 90% of the creatures die, right? We're this threat to all of life around us. And so then being a human is sort of balancing these things. And so we need to be humbled, but we need to also recognize our greatness. And so being sick allows you to say, I am not in control, that it's life, there are things beyond me. But being sick then also allows you to be in a relationship with someone like a physician or someone who cares about you, who then says, but I'm going to help you because I'm like you. I'm right now, I'm not sick, but I will be sick. And so life is better if we're taking care of each other, right? And so your sickness allows the conditions for the possibility of someone else taking care, and that taking care makes the carer better. And so we're much better off when we live in this community of perpetual care and concern than we would be if we were all, Achilles and demigods who could never be destroyed, right? We have more meaning because we're in this fight together.
I found both of those answers very insightful and eloquent. I just want to, from a philosophical point of view, it's kind of ironic because some people say life is pointless because we'll die. Other people say life would be pointless if we live forever.
Right.
But that would not be beaver. So it's like you can't win,
Almost prompts me to say that humility is something that I would like to see more of in my line of work, but anyway. I have two more questions that I hope we can address. One is about terminal lucidity. My mother had such a moment of clarity. Someone writes on her unresponsive deathbed. It was a bit shocking, but such a welcome surprise. Can you explain terminal lucidity?
I mean, I don't have a lot of experience with being pediatricians, but I mean, I think there are known phenomena of sort of endorphin and adrenaline type hormone releases that could explain that, like a restoration of brain function right at the end because of increased what are called catecholamines, things that give you more pep and verve, and endorphins that might make you feel good. So I don't know, William, if you have any comment.
Yeah, it depends on you. You want your poet hat, your philosopher hat, or your physician hat, and yeah, I think, and honestly, I think they're probably all true. But I think just because we can explain it one way doesn't exclude these alternative explanations, and I think that's the grand play is seeing all of that at the same time.
Mm-hmm. A final question that kind of we go full circle, come back to near-death experiences. It's maybe one for John. For patients or people in general who have experienced near-death experiences, what do the vast majority of them report? Is there a consensus on whether there is that light at the end of the tunnel, or is it just a void? Also, what do our panelists personally believe happens during the process of death? This is a question that merits an entire long session.
Yeah, we did one recently at the Palm Desert campus on near-death experience. Well, I'll just be really brief. There are certain patterns across time and across cultures in the reports. Usually there's an out-of-body experience. You're floating above your body. There's usually a reunion with deceased loved ones, and they accompany you, or perhaps religious figures or authority figures, through perhaps a tunnel or a darkness toward a light. The colors are lucid. The experience is coherent, unlike, let's say, dreams. Usually they feel it's very peaceful. Now, about 10% of the NDE reports are negative, and they're going down. They're accompanied, but they're going down from the light toward the darkness and so forth. Not all near-death experiences have all of these properties, but there are some patterns. Usually people who've had them experience transformations. They become less anxious about death. They become more spiritual. They become more pro-social. So there is this phenomenon. Now, my own view is they have real meaning and they're deep, and we can learn lots of lessons from them. But in my view, the lessons are not about an afterlife, but about dying and meaning that we find in life. So I think they can be, ultimately, they're going to be understood to be brain phenomena, mental phenomena that are underwritten by neurophysiological changes in near-death context and mediated by culture as well. So we see perhaps a light at the end of the tunnel in the West, and Japanese may see a rock garden because we have the trope, there's always a light at the end of the tunnel, and they have the story of peacefully tending a rock garden as they're getting older. But so it's this complex thing, but I interpret it naturalistically. So.
Thank you all. We're at 3:30. I wanted to conclude today's conversation with a quote from one of William's earlier emails, where he wrote, "Death and dying are vitally important in understanding life and living well. I think cross-disciplinary study of issues such as these is the only path to true understanding." And I think it nicely sums up our conversation and the reason why we came together here today. And in that spirit, we're grateful that you did join us for such an animated conversation on what I think is a really big, of course, and important topic in times when, death seems to follow us around, not just pandemic-wise, but now also through a brutal war in Eastern Europe. Recording of today's roundtable will be available on the Center's Vimeo channel, so please recommend to others and share the link. And as always, we hope to see you back for more big questions and other events. And thank you again, John, thank you, William, thank you, Brigham, for coming together and discussing across the disciplines what it means to die or nearly die. Thanks a lot to everyone.
Thank you. Thank you.
Great being here.